Yeah, so our next speaker is Dr. Azhar Saeed, and she's a molecular genetic pathology fellow at the University of Minnesota. She received her medical degree from Arabian Gulf University in Bahrain and her Master of Science degree in cancer biology from the University of Michigan at Ann Arbor. She completed her anatomic and clinical path residency at the University of Kansas and is certified in APCP by the American Board of Pathology. She will be completing her training in GI liver pathology at the University of Utah next year, and her research interests include genomic characterization of GI tumors. So welcome.
Thank you so much for your introduction. I'm glad to be here today to be talking to you today about molecular characterization of certain gastrointestinal tumors and what the surgical pathologist needs to know about them. So I don't have any disclosures. And the objectives for today's talk will be including molecular pathology characteristics, molecular biomarkers, and molecular testing guidelines in the following entities, including colorectal cancer, gastrointestinal stromal tumor, gastric adenocarcinoma, intrahepatic cholangiocarcinoma, and pancreatic adenocarcinoma. So we'll start with colorectal cancer. There are three main pathways for tumorigenesis in colorectal cancer. Can we move the picture? Because like, I think, oh yeah, I was able to move it. Sorry, or just maybe minimize it. So sorry about that. So there are three major tumorigenesis pathways in colorectal cancer. These include chromosomal instability pathway, microsatellite instability pathway, and CBG island methylator phenotype pathway. First pathway we're going to talk about is microsomal instability pathway. This pathway represents 85% of colorectal cancer, has been classically described as adenocarcinoma sequence, and it was proposed in the 90s by Vogelstein and Ferron. This pathway is characterized by frequent chromosomal alterations and chromosomal arm gains and losses, most specifically, importantly, as 18q region, which has the DCC, SMAD2, and SMAD4, which are important regulators of transforming growth factor beta pathway. And this pathway is also characterized by somatic alterations, including APC, which is an important regulator for canonical wind pathway, and also KRAS and TP53 mutations. Those aberrations are added in additive fashion, although invariably, but it has been thought that APC loss is one of the initial events, and TP53 inactivation is a late event before invasive carcinoma. The next pathway is microsatellite instability pathway and represents 15% of colorectal cancer. Hallmark of this pathway is deficiency of mismatch repair proteins. The most four proteins that we test for in practice is MLH1, PMS2, MSH2, and MSH6. This can arise sporadically in 12% of cases, most commonly in the context of CPG island methylator phenotype, and there's an overlap with the SIMP pathway as well. As methylation of MLH1 can lead to loss of this protein and subsequently microsatellite instability. 3% of cases arise in the context of Lynch, leading to germline mutation in those proteins, most commonly in MLH1 and MSH2, and infrequently in PMS2 and MSH6. There is also a 2 to 3% rate of EpCAM gene deletion, which is a gene upstream of MSH2 that leads to MSH2 loss as well, and subsequently germline mutation and MSH2 and microsatellite instability. I would like also to highlight that 70% of mutations in the context of Lynch is truncating, linked to loss of those protein, but there is also a certain percentage of missense mutations that can occur, and these impact the enzymatic function of the protein without affecting the expression. So when you do the IHC, you can find those proteins expressed, but they have an impacted enzymatic function of repairing DNA. The third pathway, the SIMP pathway, this is also called serrated neoplasia pathway, and it represents 30 to 35% of cases of colorectal cancer. It's characterized by frequent BRAF mutation as an early event, as well as global hypermethylation impacting CpG island and gene promoters, leading to silencing of those genes. Most commonly, it will impact tumor suppressor genes. And if it didn't impact any of the MMR protein, this phenotype will be characterized by microsatellite stable phenotype. But if it did impact one of the mismatch repair protein, most commonly in this context, MLH1, this will lead to microsatellite instability. So there's an overlap between, as we mentioned, between the MSI and CpG in that context. This is just showing the TCGA molecular subclassification of colorectal cancer with a lot of overlap between the pathways that we have mentioned. But I just want to highlight here that there is a non-hypermutated type and hypermutated type. And in the hypermutated type, there is a 3% of cases in this cohort that are characterized by unusually high TMB, above hundreds, and are characterized by POL-E or POL-D mutations. Sometimes these cases manifest as MSI instability high phenotype, but a certain percentage can also manifest as microsatellite instability. So they would not show a high, despite showing a high tumor mutational rate, they would be characterized by microsatellite stable phenotype. The other molecular classification that has been done so far for colorectal cancer is based on gene expression profiling that was compiled by the Colorectal Cancer Subtyping Consortium. And you can see here that there are 4 subtypes of colorectal cancer with different deregulation in different biologic pathways. And these include immune, canonical, metabolic, and mesenchymal. These have prognostic correlation as well, but it's not currently validated, clinically validated at this point, and we need further studies to imply them and translate them into clinical practice. So let's move forward and talk about the molecular testing guidelines and colorectal cancer. So I just want to highlight briefly the NCCN treatment management guidelines for colorectal cancer broken by stage. As you can see here, that most of our targeted therapy and molecular testing would be for stage 4, that's the metastatic disease in colorectal cancer. And we do MSI for all stages, but important predictors for prognosis as well as therapy as MSI in stage 2, and this is a heterogeneous category that we don't have any current consensus as far as treatment for this category, apart from morphologic, certain morphologic, pathologic and clinical characteristic of dividing these into high risk, stage 2 with high risk features and another stage with no high risk features. And we'll touch upon these in subsequent slides. So why do we do microsatellite instability testing? MSI testing is mainly indicated to screen for Lynch syndrome, as previous clinical criteria has proven not sufficiently sensitive. And these include the Amsterdam criteria 2 and the Bethesda guidelines. So currently NCCN guidelines recommend universal MMR IHC or MSI testing in all newly diagnosed colorectal cancers. And the testing methodology indicated is either MMR IHC or MSI. Most places would start the algorithm with MMR IHC because it's fast and inexpensive, and it also can identify the defective protein in this case. If you have MLH1 and PMS2 loss, that would reflect the testing to MLH1 methylation and BRAF analysis. And if this positive, that would mean those cases are sporadic, but if not, those cases would be reflected to germline analysis. MMR IHC has the benefit of also working with low tumor purity cases. Unlike MSI, we need a high tumor purity sample, a certain tumor percentage for the assay to be optimally kind of give a reliable result. But there is also a false negative rate that can happen in the IHC. And as we have discussed before, like missense mutations affecting the enzymatic activity, but not the heterodimerization and stabilization of those proteins. So those proteins can be expressed despite having defective function. As far as the MSI PCR, there's a concordance rate between the MSI and IHC as far as colorectal cancer of about 88 to 94%. Most of them have like kind of similar sensitivity, but they can miss certain cases here and there. Assessment can be done by PCR and NGS. Difference is that NGS assess large scale microsatellite loci versus the PCR which interrogate certain microsatellite loci. MSI testing by PCR, as we have mentioned, will interrogate certain microsatellite loci and will analyze those loci for expansion or contraction by analyzing the fragment size, doing fragment size analysis. And there are currently two panels that are in use, the Bethesda NCI panel and the Pentaplex panel. The Bethesda NCI panel uses 3 mononucleotide and 2 dinucleotide markers, and I would say that the mononucleotide markers are more sensitive than the dinucleotide. That's why this panel has a lower sensitivity than the Pentaplex panel, in which all of the panel markers used in this panel are mononucleotide markers. The Bethesda also require normal tissue for analysis, while the Pentaplex does not need normal tissue. As far as analysis goes, if we have 2 or more markers shifted, that's considered MSI high, or even if we have any size alteration of more than 40% of the total markers used, that's also considered MSI high. If you have 1 marker shifted, that's considered MSI low, and if there are no markers shifted, that's considered microsatellite stable. You might wonder what's the difference between MSI low and microsatellite stable. These are clinically, these behave the same, though we report them as MSI low versus MSI microsatellite stable. This picture shows the MSI PCR enhanced assay that we use, and you can see about the tumor sample compared to the normal and the microsatellite markers. All of the microsatellite markers in the tumor shifted to the left, consistent with contraction of those repeats. So is there any prognostic role for microsatellite in colorectal cancer? As we have mentioned before, yes, there's a prognostic role for MSI, and it's a stage-dependent role. So in stage 2, MSI high stage 2 colorectal cancer are associated with improved prognosis in comparison to microsatellite stable cancer, and they are also associated with reduced incidence of lymph node spread and metastases. This is in comparison to stage 3 and 4 colorectal cancer. The MSI high colorectal cancer high status had no prognostic effect on overall survival. As far as predictive role for adjuvant therapy, of course, MSI has also a predictive role as far as predicting benefit for 5-fluorouracil, which is the most common chemotherapy regimen used in colorectal cancer, especially in deciding as far as like adjuvant treatment in stage 2. So MSI high colorectal cancer, as you can see here in the blue line, the microsatellite high treated cases show worse progression-free survival in comparison to the non-treated group. And in stage 3, microsatellite treated compared to the untreated show no difference in progression-free survival, so clearly there is no benefit. This is in comparison to the microsatellite stable cases in stage 3, in which treatment with 5-fluorouracil in this group show clear benefit in comparison to the non-treated group. MSI is also a good predictive biomarker for immunotherapy, especially in stage 4 metastatic colorectal cancer. As it has shown, the MSI high metastatic colorectal cancer treated with pembrolizumab has a better overall survival in comparison to the chemotherapy treated group. So immune checkpoint blockade is currently FDA approved as first-line therapy for MSI high colorectal cancer, and this testing should be performed. As we have said, it's universal, but it's specifically important as predictive therapy in stage 4. And the currently approved agents are pembrolizumab, or we can use nivo plus minus ipilimumab. Moving forward to predictive biomarkers for response to EGFR targeted therapy. EGFR targeted therapy is an important component of targeted therapy in colorectal cancer, mostly utilizing monoclonal antibodies, including cetuximab and panitumumab targeting the EGFR receptors. The most predictive biomarker that established biomarker that we currently use is RAS and NRAS. Although you can see there are many proteins in this pathway that can be predictive, but they are not currently established as predictive biomarkers, and we need more studies clinical studies to establish their roles. These include PI3K, PTEN, and also BRAF. So as far as like KRAS and NRAS mutation testing, studies have shown survival advantage for adding anti-EGFR monoclonal antibodies therapy, as we have mentioned, panitumumab and cetuximab for KRAS, NRAS wild-type colorectal cancers. And mutations in NRAS and KRAS are associated with no response to anti-EGFR monoclonal antibody therapy. Why is that? Because these mutations usually affect the GTPase activity of those proteins, locking RAS in a GTP-bound active state, leading to constitutive activation of those proteins and eventually downstream signaling. So no matter if you block the EGFR receptor or not, this pathway is going to be constitutively active because of this mutation. Mutation in KRAS represent about 44.7% of colorectal cancer, while NRAS happen at a lesser frequency at 7.5%. And currently, there's like before we used to do codon 12 and 13, but the current recommendation recommends extended codon testing for the codons that you can see here. Moving on to BRAF. BRAF has an important prognostic role as a biomarker, especially in the context of microsatellite stable tumors. As you can see here in red, that BRAF mutated microsatellite stable cancer have worse overall survival of all groups. And also in the MSI high cases that are BRAF mutated here in blue, you can see that they perform worse than the green MSI high and BRAF wild type. The MSI high, as we have mentioned, they're supposed to have worse prognosis, but probably the prognosis is ameliorated here because of the MSI high status. As far as HER2 and colorectal cancer, HER2 alterations, including amplifications and activating mutations, occur in about 5% of colorectal cancers, and they're usually mutually exclusive with other oncogenic drivers in MAPK and PI3K AKT mTOR signaling pathways. Currently, at this point, they don't have any clear prognostic significance, but they may predict lack of response to anti-EGFR therapy, but this is not currently clinically established yet. But most importantly, HER2 has a predictive role for anti-HER2 targeted therapy. And per the Heracles trial and other early phase trials, HER2 amplified tumors with RAS and BRAF wild type status showed good response to HER2 targeted therapy with 30% objective response rate. So currently the NCCN recommends HER2 testing in metastatic disease either by IHC, FISH, or NGS. And the Heracles trial also established diagnostic criteria for positivity of HER2 amplification in the context of colorectal cancer by using IHC or FISH. In the context, if you're using IHC, you'd expect the positivity to be a 3+ staining in more than 50% of tumor cells. If you're using FISH, the HER2 CEP17 ratio should be more than or equal 17 to qualify for anti-HER2 therapy. The other biomarker that we're going to talk about is NTRK, which stands for neurotrophic tyrosine kinase fusion receptors. Though this is rare, why we are talking about this? Because we have FDA-approved targeted therapy for this fusion and colorectal fusion that can target this fusion and also other tumor types, but this happened at a rate of 0.4% in colorectal cancer and mostly involve fusions of NTRK1 and 3 proteins with other proteins. This is enriched in MSI high colorectal cancer, especially MLH1 promoter methylation, and also associated with RAF wild type. So currently, as I've mentioned, there are FDA-approved therapy targeting NTRK fusions. These are entrectinib and lorlatinib, and detection methods that are recommended for detection of fusion include IHC, FISH, and NGS-based assay. These include DNA-based and RNA-based, and I would say that RNA-based NGS are the most superior in detecting NTRK fusions, especially in colorectal cancer, since NTRK3 is one of the most involved proteins, and it's kind of challenging to do it by DNA, and RNA is more optimum because it does have better coverage and also a better sensitivity in detecting those fusions. Okay, shifting gears now and moving to gastrointestinal stromal tumors. Gastrointestinal stromal tumors are the most common mesenchymal tumor in the GI tract. It arises from interstitial cells of Cajal. Most of the cases arise sporadically, but 5 to 10% occur in association with variety of syndromes. Most common drivers include KIT, which is mutated in about 70 to 80% of cases, as well as PDGFR alpha occurring at a lower frequency of 5 to 15%. There are cases that are also wild type for KIT and PDGFR alpha. These include 10 to 15% of cases. Most commonly occur in association with BRAF V600E mutation that can occur in hereditary syndrome affecting succinate dehydrogenase complex A, B, C, and D, and also in the context of SDH hypermethylation in the context of Carney triad. They also can occur in the context of neurofibromatosis. We're gonna focus on the most common drivers, KIT and PDGFR mutations. So KIT and PDGFR are receptor tyrosine kinases. They do have similar structure, structural domains, including extracellular domain, juxtamembrane domain, and they have a split tyrosine kinase domain. KIT is usually associated with more aggrosubgest, and most common mutations in KIT would occur in exon 11. These most commonly occur in the stomach, associated with spindle morphology, and highest response to imatinib, which is the tyrosine kinase receptor used in this context, and also associated with better outcome. Mutations in the tyrosine kinase domain of KIT are associated with secondary mutation and secondary mutation related to resistance to imatinib. Exon 19 mutations correlate with benefit from higher dose of imatinib in comparison to the usual dose used. Regarding the PDGFR alpha mutations, these are most commonly associated with epithelioid gist. Most common mutations occur in exon 18, and I would kind of specify here that this mutation, the 842V, is associated with primary resistance to imatinib, while non-D842V mutations in this exon is associated with poor prognosis. Exon 12 mutations are associated with better outcome in association with PDGFR alpha. Moving on to gastric adenocarcinoma. Gastric adenocarcinoma is actually a heterogeneous disease, and there have been multiple efforts to kind of implicate molecular subclassifications. As you can see here, it started in 2011 till 2015, but it has not been successful in capturing this heterogeneity, but the most comprehensive of which is the Cancer Genome Atlas subtyping, which was done in 2014, and we'll be touching on this subclassification. So the molecular subtypes of gastric cancer implicated by TCGA include EBV-driven category, microsatellite unstable, genomically stable category, and chromosomally unstable. And I would highlight here that the MSI category has the highest TMB of all in comparison to the other subtype, which has kind of low to moderate TMB. Let's start with the EBV positive subtype. This constitutes about 9% of cases, and it's usually EBV driven. The integration of the EBV genome earlier on, it has been studied well, and it has been thought that it leads to extreme DNA hypermethylation of CpG islands, leading to silencing of many genes, including tumor suppressor gene. And peculiar to this category is the CDKN2A, which encodes P16 protein. This commonly occur in this category. And what is peculiar also about this category is the hypermethylation. And this subcategory doesn't kind of mirror any subcategory in the TCGA atlas. It has the highest hypermethylation of all cancer types. It is also characterized by recurrent mutations in many genes, including PIK3CA, as well as amplifications and overexpression of PD-L1 and PD-L2 in 15% of cases, making this a great target for immunotherapy. As you have seen in the previous slides, it was associated with low TMB, which you might infer that it's not like a good predictor for immunotherapy, but this amplification probably qualifies it for immunotherapy. It is also associated with amplification in HER2 and JAK2. Location-wise, it's mostly associated with gastric fundus and body tumors, and histologically associated with lymphoid stroma and lymphoepithelioma-like stroma. Most common patients are male patients in this category. Microsatellite unstable subtype constituted about 22% of the cohort in TCGA and is characterized by hypermethylation, leading to MLH1 gene silencing. It is also characterized by high prevalence of occurrence in females and older age, and also a high tumor mutational burden. And mutations characteristically happen more frequently in receptor tyrosine kinases and ERB family of genes, including EGFR and HER2 and HER3. Genomically stable subtype constitute about 20% of cases and is peculiarly characterized by diffuse type histology in 73% of cases, and occurrence in younger patients. And it has been shown that there's a deregulation in genes involved in cell adhesion and motility, including CDH1 and ROV family of genes, which is RAS superfamily members. And because of deregulation of these genes, it was thought that this contributes to the diffuse type histology seen in this category. This category is also associated with worse survival benefit with adjuvant chemotherapy. The chromosomal instability subtype constituted about 49% of cases, and it is associated with intestinal histology, most commonly occur in gastroesophageal junction and cardia, 65% of cases. Molecular alterations include different mutations and amplifications, also on receptor tyrosine kinases, including ERB family, as well as FGFR2 and MET, as well as cell cycle mediators, making this category an exciting from targeting therapy perspective. This category is also associated with greatest survival benefit with adjuvant chemotherapy. Currently, there are these approved therapies in gastric adenocarcinoma, including trastuzumab in first line, anti-VEGF ramucirumab in second line, and Pembro in second line as well. And we can use antibody drug conjugate targeting HER2 in the third line setting. So as far as like HER2 amplification and gastric adenocarcinoma, it was found by TOGA trial that trastuzumab anti-HER2 prolonged survival in HER2 amplified gastric adenocarcinoma compared to chemotherapy alone. So HER2 testing is currently indicated for inoperable locally advanced recurrent or metastatic gastric adenocarcinoma. And the method implied here is using either IC or FISH. As far as immuno-oncology biomarker in gastric cancer, FDA approved PD-1 inhibitors, pembrolizumab, for universal use in most cancers that display MSI high, PD-L1 scores, and also TMB high status. And this study, the KEYNOTE-158, also included gastric cohort in their study, showing overall survival benefit with Pembro. So now Pembro is FDA approved, and testing these immuno-oncology biomarkers in metastatic locally advanced or recurrent setting is indicated. So as far as like NCCN recommendation, MSI is currently recommended, MSI testing is currently recommended for all newly diagnosed gastric cancer per NCCN guidelines, and PD-L1 and TMB testing may be considered for locally advanced recurrent or metastatic gastric cancer setting, but MSI has priority. So moving on to intrahepatic cholangiocarcinoma. Molecular intrahepatic cholangiocarcinoma is interesting from the perspective that we have many targeted therapy, and there's also histological molecular correlates in the setting. So in the small duct type, there are recurrent mutations that can happen. Most importantly, IDH1 and 2 mutations that occur in 10 to 30% of cases. Also, FGFR2 fusion occur in 10 to 25% of cases of small duct type. BRAF mutation is rare, but do occur only in the small duct type. The large duct type is interesting in a sense that it is genomically mirroring the extrahepatic cholangiocarcinoma, and it's characterized by frequent KRAS and TP53 mutation. There are also certain clinical categories that have molecular correlates. These include liver fluke-associated cholangiocarcinoma, and what GNAS mutations has been observed in 9.2% of cases. Seropositivity for hepatitis B has been associated with TP53 mutations in those cholangiocarcinoma that arise in this context. Also, KRAS mutation has been thought to be an early event in primary sclerosing cholangitis and hepatolysis-associated cholangiocarcinoma. So I mentioned that these mutations are exciting from a targeted therapy perspective. So IDH1 and 2 mutation has been targeted by IDH1 inhibitor in by ivosidenib, and ivosidenib treated cholangiocarcinoma has been shown in trials to display better progression-free survival in comparison to the placebo group. So IDH1 inhibitor is currently FDA approved and recommended by NCCN as a subsequent line treatment option for metastatic or locally advanced cholangiocarcinoma. So in this setting, you would want to test for IDH1 and 2 to select patients for this therapy. Also, FGFR2 fusion has shown a really good objective response as far as like targeted therapy in trials using pemigatinib. And you can see here that there's a really good objective response rate in this trial that used pemigatinib. FGFR2 fusions can happen specifically in this setting, although other FGFR2 fusions can happen in other cancer. The mechanism of which is that FGFR 5' which contain the tyrosine kinase domain, can fuse with other partner genes, and this fusion lead to constitutive activation of downstream signaling, leading to progressive growth, tumor invasiveness, and also chemo resistance. So NCCN guidelines currently recommend using pemigatinib or infigratinib as a subsequent line treatment option for metastatic or locally advanced cholangiocarcinoma. Other least frequent biomarkers, as we have mentioned, NTRK, you'll see this across the categories, but NTRK inhibitors are recommended as first line or subsequent line treatment option following disease progression in unresectable or metastatic cholangiocarcinoma with NTRK fusion. Also, BRAF V600E, though it happened at like a rate of 1%, but since we have targeted therapy for BRAF in this setting, including BRAF inhibitor, dabrafenib, or MEK inhibitor, trametinib, can be used to target this mutation in the context of cholangiocarcinoma in metastatic or unresectable setting. So we might want to consider testing for this and this setting. As far as immuno-oncology biomarker, we mentioned that the KEYNOTE-158 trial, based on this trial, the FDA approved pembrolizumab for universally for tumors that display high MSI, TMB high, or PD-L1. And this trial also included a cholangiocarcinoma cohort that display benefit from a survival perspective with treatment with pembrolizumab. So NCCN recommend PD-1 blockade pembrolizumab in unresectable cholangiocarcinoma cases that have MSI high or TMB high as a subsequent line treatment option. So we also want to test for MSI and TMB also in metastatic setting. Okay, moving on to pancreatic adenocarcinoma, which is my last category. So comprehensive genomic profiling has been done for pancreatic cancer, and it has consistently showed 4 aberrations. These include KRAS mutations and other tumor suppressor genes, including TP53, CDKN2, which encode P16, and SMAD4 loss. Though they are recurrent, but we don't have any targeted option at the time for these aberrations. So it might seem that we don't have any kind of like in our repertoire of targeting pancreatic cancer, we don't have any targeted therapy. But there's a lower prevalence of mutations that happen in other genes, as you can see here in the graph, epigenetic modulators that have been like developing therapeutics in trial, but they have not been established yet. Also, lower prevalence of DNA damage protein mutations occur in pancreatic cancer, but at a lower frequency. So regarding DNA damage deficiency in pancreatic adenocarcinoma, it has been observed that mutations in homologous recombination repair gene mutations occur at a rate of 15 to 20% most commonly in BRCA1, 2, ATM-RAD51, and CHIK2. These are main proteins in the homologous recombination pathways, and this pathway impacts double-stranded DNA repair, and this any double-stranded DNA repair would be repaired by this pathway, as well as another pathway which is called non-homologous end-joining pathway. This is a less efficient pathway in repairing damage and is error-prone. So pancreatic adenocarcinoma that has impacted homologous recombination repair would rely on this pathway to repair any damage that occur in this context, but because this pathway is error-prone and it will lead to certain genetic signatures across the genome that we can detect, and also genomic instability. So these genomes have been described as unstable, displaying more than 200 structural variants. And among the mutational signatures that are kind of unique to HRR pathway deficiency include tandem small duplications, microhomology mediated end joining, and those are related to non-homologous end joining, performing the repair of those double-stranded break, leading to small indels across the genome. This is in addition to also certain cosmic signatures. These are specific single nucleotide variations across the genome that occur as a result of HRR deficiency. So we can use also those signatures as far as like biomarkers to predict that there is a damage in this pathway. So tumors with homologous recombination repair deficiency are sensitive to platinum-based therapy because they cannot repair the damage implicated by those therapies. And they also display prolonged overall survival if treated with platinum-based chemotherapy. They also display synthetic lethality with poly-ADP ribose inhibitors. And the mechanism that those PARP inhibitors and how they form synthetic lethality is not really well understood, but it's thought that PARP inhibitors can lead to accumulation of single-stranded breaks in the replication forks, and those can be progressed to the double-stranded breaks that cannot be repaired by HR deficient cells in the case of pancreatic adenocarcinoma, leading to apoptosis and cell death. So what are the biomarkers that we currently use for PARP inhibitors? Currently, in our repertoire, we only have BRCA1 and 2 germline mutations. That's currently the most feasible biomarker used to screen patients as far as like selectivity for PARP inhibitors. But there are also large-scale biomarkers, but they're not currently clinically validated, but they might be soon in the soon future. This includes the loss of heterozygosity score. As we have mentioned, those cells rely on the non-homologous end joining pathway, so they will have like microdeletions across the genome that's overrepresented, and there are computational methods to kind of detect this mutational signatures. But it's as I mentioned, it's not currently validated at the time. And there are also another genomic signatures that can be detected by computational method, not including only loss of heterozygosity score, but other genomic signatures is called homologous recombination deficiency score. This is currently approved for ovarian cancer PARP inhibitors in the context of ovarian cancer, but it's not currently approved for pancreatic cancer, but it might be in the soon future. So as far as like pancreatic cancer, standard of care therapy mostly relies on systemic therapy, adjuvant chemotherapy, which is platinum-based in all stages. But we can use, as I said, pembrolizumab for MSI high tumors and metastatic disease, and also NTRK fusion positive tumors. We can target them with NTRK fusion, NTRK inhibitors in metastatic disease. As far as like PARP inhibitors, olaparib use, it is only used in maintenance therapy in metastatic pancreatic cancer with germline BRCA1/2 mutation after platinum-based therapy at the time. So that concludes my talk. Thank you so much for paying attention, and I would be happy to take any questions.
That occurred to me, which I don't know, you may or may not have an opinion on.
Yeah.
Come up here again, I'm sorry.
Yeah.
Otherwise, oh, you have a comment, great. Yeah, so I had something that occurred to me, which I'm not sure if you'll have an opinion on, but we have sort of different requests from, again, our different clinicians, like some of our outside clients versus our in-house physicians regarding like next gen sequencing. We happen to use Tempus. I don't know if you're familiar with Tempus. So, but then we have some other people who prefer to sort of do like one-off orders, like for colorectal, maybe they'll do KRAS and then they'll do like multiple tests. And from a standpoint for us, if you have like a small amount of tissue, we sort of prefer to send it to Tempus and hope that we get a result.
Yeah, right.
So do you have any comments on that, kind of picking and choosing versus doing a whole big panel?
At the current time, it seems like comprehensive genomic profiling is the approach for small biopsies, but we do have like, yeah. So I think like comprehensive genomic profiling would be the optimum approach at the current time, meaning that like NGS testing that interrogates DNA sequence mutations as well as structural variants, as well as like, fusions, in addition to, as we mentioned, MSI and TMB. Those comprehensive panels would be the most optimum option because you can use like small biopsies and then use them as in the same workflow, and then multiple patient samples can be multiplexed also in this assay. So it's kind of faster rather than splitting this like, biopsy precious material between assays. But I think a lot of places are moving forward with like, doing that. But as far as like in-house experience, we do NGS assays for like multiple panels, and we are bringing also the Archer Fusion panel, which is like an NGS based also. So we'll be using like the same biopsy sample in the same assay in the same workflow. And that Archer Fusion panel is currently unique in that like you don't need to know the fusion partners, and it interrogates multiple fusion partners, like over 100 genes, gene loci. So you can look for multiple fusions as well in this assay.
So thank you very much for that very nice presentation. One comment, so there was an allusion to the use of HER2 staining in colorectal cancer. And, it was correct that Heracles has some criteria, which speculates that you have 50% of the tumor cells positive to be 3+. So now there's a lot of controversy about that. And so when we have to do HER2 immunohistochemistry from colorectal cancer, the recommendation and the suggestion for today is to use the gastric criteria, which requires only 10% of the cells to be positive. And so when you get a 2+ staining in 10%, not 50% of the stain, that gives the patients the opportunity to request HER2 fish in those patients. And I think there's enough data now to confirm that a lot of patients with, between 10 and 50% 2+ staining actually have R2 amplification in those patients. So the RRQs is probably not going to stay around for a long time. But right now, the CAP doesn't really have a specific guideline about the colorectal carcinoma and HER2 reporting. So I just wanted to, bring that one out. If you have to do it, use the gastric cancer criteria to report that. And if you think it's just 10%, send it for HER2 fish. Now, my question, that was again very good. And this is a question of somebody who's probably more of a novice from molecular. You always tell us about NGS solid tumor panel. And my understanding is always that most of these genes, the KRAS, of course, the EGFR and everything are on that panel. So is that correct? So when we have a tumor and we are asking for, so what I just asked for colorectal cancer panel, because I'm not even sure what to pick, whether it's just the KRAS or the PR. So, but my understanding is that most of the solid tumor panels have pretty much everything you need, irrespective of which part of the GI is coming from. Yeah, you need to.
So there's a differences between the NGS panel as far as like the design, like probably you can interrogate as much as targets as you can, but it depends on what you validate in-house as far as like your targets. So the number of validated, like depends on what you validated in-house. You can have like, for example, for the solid tumor panel, you can have like, for example, a 70 or 100 or so, maybe 500 genes in that panel. But when you want to analyze, if you specifically request that I want to look at colorectal cancer specific genes that most probably clinically relevant, then the analysis would be more specific to that genes. But for example, we kind of blind all the other kind of findings from the genome and we kind of specifically analyze those genes. But we can, if there's any request to look for other genes, for example, then like we can look back, like bring back the, the analysis for those genes, I would say. So it depends on what you have in-house, and then like different places have different like gene panels as far as like what they validated, and then what they interrogate as far as like regions of like specific genes.
All right. Well, I think that means we get to move on to our break. Thank you very much.